the debates this morning were so dynamic, and I think what actually was overwhelmingly interesting is that LASIK still has such a strong presence in refractive surgery. They kept winning the debates. You know, the audience and the panelists that were debating LASIK were like, LASIK is tried and true. Patients have had really great outcomes. We know the technology and we've seen its evolution, you know, over the last 20 years, and we can really confidently recommend it to our patients. So I think that was very interesting to me, because I do think we are seeing the shift for interest in KLEx as well as ICL, and I think both are wonderful technologies and they play a really strong role in refractive surgery. But I was pleasantly surprised by the overwhelming interest in still performing LASIK for many patients. I think it's so important to kind of understand where the patient is at when you meet them. You know, where in the severity of their keratoconus are they at? What are their goals? You know, sometimes these treatments, as we heard in the debates, can be trickier. They're not as predictable from a refractive perspective. And so, you know, I think Dr. Kanellopoulos made an interesting comment in the sense that you're really trying to stabilize the cornea and treat those higher order aberrations. You don't want to fixate on the actual prescription that you're treating. And that really allows that patient to gain the benefit of that combination treatment. Because I think the thought is that if you potentially do them sequentially, are you strengthening the cornea and then removing all the cornea that was already strengthened? What is the effect of the cross-linking? Is it an uneven cross-linking procedure depending on where the cornea was cross-linked? And does that affect then how the topographic treatment is going to affect the cornea after? I think that ultimately it's great for these cases to be in the hands of the surgeons who do a lot of these, because I think there's a nuance in terms of how you're performing these techniques. And outside the United States, they have different cross-linking protocols that can also be implemented. And so if you're doing an accelerated cross-linking protocol, I think that's going to kind of enhance the efficacy of the treatment or the speed of the treatment than doing our standard FDA-approved protocol that we have in the United States. So I think the jury is still out, and I think that's why it's been a debate for many years on the podium. And I think as we see more and more keratoconic patients in our practices, we are all so eager to find wonderful treatments for them, because these patients are often told they don't have options, but I think we are now seeing more and more options. It's not just laser vision correction in the sense of topography-guided treatments, but we're thinking about tissue addition procedures like CTAK or even EVO ICL in stable patients. They do have opportunities for vision correction. And I think those have been technologies that I've personally loved implementing into my practice for my keratoconus patients.